Thank you, Joe. And I'll come back here. So I'm going to start with, we're doing that. And so definition, what is a league position? It's a policy statement. It guides advocacy. The only reason for it is so that you can go in front of a legislature or a chamber or a regulatory body and say, we want you to do this, we don't want you to do that. If you have a position that says the league supports X, you don't have to advocate for X. You're not allowed to oppose X, but having a position allows you to advocate. So we just want to be highly clear about that. Concurrence is when a league adopts a position without studying it because another league has studied it. All they decide is whether they agree with it and want it, and they fully understand it. They don't have to do all the research. So how often does concurrence happen? All the time, because doing a study is massive work. When New York studied its healthcare position to create a new one 4 years ago, we probably put in 2,000 hours, just so you know, which is, one person full-time for a year. So what does the Vermont update change? Basically two things. One, it defines healthcare as a public good. Second, it adds accountability to the US criteria. Arguably, both of those are currently true, but there's a lot of inconsistency in the interpretation because the US calls healthcare a moral, a human right, and a human right is automatically a public good. But of course, it doesn't say it's a public good. So part of what Vermont wanted to do was make sure that the US couldn't go back and forth about whether healthcare was in the privatization position or not. Secondly, the privatization position is quite robust. It has criteria for whether privatization is warranted and how it would be regulated and what the controls ought to be put in, but it's not explicit about recourse if there's failure to meet the criteria. And the US says, of course, every US position implicitly has accountability if you fail the guidelines. But when you ask the US to do that, they say, nope, can't do that. So this is just to make it explicit. And by the way, with the New York health position, part of that was to get rid of bad interpretations as well, because while the US position on healthcare did not mention single payer, that phrase was not in the position. So North Carolina used to say it's against single payer because it doesn't have it. And every other state, California and New York, were saying, of course it does. So by putting it explicitly into the US position, you make it clear. Same way the US position appeared to say you couldn't have a state healthcare position. New York state position said, of course you can. Now the US position says, of course you can. So now that interpretation. So that's part of what's going on here. So I've divided the update into three pieces. The first paragraph is what I call the public good paragraph. And when Joe starts, I hope the first thing we can do is, I don't want to bias you, but this is the education thing. I think the US and New York already support this, that we believe healthcare, like other programs that provide and protect basic human needs, should be considered a public good. Next one, slightly more controversial. The League favors a system where fiduciary responsibility is to the patients or the public. And we will explain what fiduciary means. We'll discuss fiduciary in just a minute. Because private for-profit corporations have a fiduciary responsibility to their shareholders rather than to patients or the public, the League believes the for-profit business model for providing healthcare or other public goods is inappropriate for the common good or to meet the basic needs of the most vulnerable members of society. So if you think about whether the poorest and most rural and other sorts of residents of New York State are having their health care needs met. Those would be the most vulnerable members of society. These are current
Hi, so what can
for-profit
I do to
systems.
help you?
What?
I don't know. I mean, every time I
Okay.
press the
Joe, would you
join
like to
meeting,
move?
it just
That person?
goes back to nothing.
Oh,
I was just trying to get it on my phone. I don't know, maybe
Yeah, I'm looking for that. for the
okay,
individual.
I
I'm
had the wrong connection. I didn't try.
Thank you. Okay, so, and then the third piece, I'm saying it has two pieces, opposing further privatization and adding explicit accountability, and that would include up to deprivatizing. So it's not bimodal. You're either in or you're out. There are places between you're telling an entity that they aren't working right and deprivatizing them, but deprivatizing is the one that you have to be able to allow so that you can do everything in between. The position reads, in sum, the League opposes further privatization of needed healthcare, and where private entities fail to deliver programs that provide and protect basic human needs, the League supports deprivatizing them. So to be clear, this entire position is talking about public goods and in several places specifying healthcare, but it is all about public goods, owning, managing, controlling them, not about selling bread or jewelry or tires. It is only about things that were considered public goods. So why paragraph 1? Very briefly, New York says that New York League says that New York must assure high quality care that's affordable and accessible to all. It should protect the health of its most vulnerable populations, and it favors broad-based progressive state taxes and income taxes to fund it. And the US says in their meeting human needs position that persons who are unable to work, whose earnings are inadequate, or to whom jobs are not available, have the right to ... access to health care. So I think it's already there. You can decide whether you...
Well, hang on. Just
Go ahead.
so I'm clear, that's the US is saying that people who have inadequate earnings have a right. They're not saying everyone has a right to access to health care.
Oh, that's true. In another place, which I didn't have here, they're talking about it is a right to health care. And I should
But
have...
everybody has a right to health care.
Yeah, it is a right. It is a, what do they call it? A moral right. But by the way,
Okay.
that conforms to the UN, to the World Health Organization, to the Declaration on Human Rights. Healthcare is always listed in there.
Okay.
And they mean that as a fundamental right to health care. That
There is a fundamental right to healthcare.
Right. Every human has
Every
a
human.
right.
And one of the things that's interesting is that there are many, many rifts around healthcare is actually a national security issue, because if your population is unfit, they aren't going to be able to be in the military. They're not going to be able to make the country economically strong. They won't be good employees. So healthcare actually makes a country economically and security-wise stronger, which I think we may get to, but okay. Paragraph 2. So what's fiduciary mean?
Is this legal right?
Adequate health care?
To
what extent health care? Basic health care, basic health care needs?
There's some question about what basic health care means.
Yeah.
It certainly means health care that will keep you alive or healthy. It surely does not mean nose jobs.
Right.
Or
But the third paragraph is referring to needed health care. And it's not defined anywhere.
No, it isn't.
So I think Laurel is asking just how broadly is that defined? Is
Right.
that preventive care? Is that emergent care? Is
So
it,
in the New York State position, there is a very, very long list of all the things that are for sure included. New York calls it essential rather than
Right, essential.
essential care. And that's outpatient, inpatient, prevention, education, and mental health, behavioral health, eyesight, ears, hearing, eyesight, everything above the neck,
okay,
teeth, healthcare, things that
So
keep
is-
you healthy.
But not
Okay.
custodial,
not just keep you healthy, but get you healthy if you're not?
Yeah, keep you
not
healthy and get you
custodial,
healthy.
not custodial though.
Actually, well, what do we mean by custodial? If you need home care,
Unlimited nursing care.
yeah, you get, if that is
You
what you,
don't get unlimited nursing care.
Hang on.
No,
Unless you
May I,
authorize yourself.
I'm so sorry. I haven't had even a chance to introduce myself, but as your facilitator, may I say that
Oh,
these
okay.
questions are awesome, and that there really ideally should be discussed during the discussion. So
Okay.
this is the education section, and these are great questions. So I hope, please let's get to them, and we want to get through the education, and then we will absolutely have the opportunity to discuss, because we're going to turn off the recording, by the way, after
Yeah.
Judy finishes, so that
Okay.
everyone really feels can speak very freely about this and talk about it. So if that's okay, let's go through the education, and then really let's have a robust discussion at the time.
thank you, Joe. And by the way, if you want to capture questions in the chat so that when Joe's starting, I will look at them so I can be more expeditious, that would be great. So if somebody wants to ask that, I could probably show what the New York Health position shows, for example.
Okay.
Does that make sense?
Yeah.
Thank you. Let's see, where am I?
Should do the education on, I think, on the third piece.
Yeah, and I do not know where my shoot.
there you are.
Okay. So why paragraph 2? Fiduciary duty. In any context, it's a person who is ethically or legally obliged to act in the best interest of another party. So a doctor or an accountant takes on a fiduciary role when they are supposed to give you their best assessment of what you have or need. An accountant is not acting like a fiduciary if he pockets some of your money or, does things that help him, not you. And where it often comes in is when you're talking about a financial advisor, many of whom are not legally required to be fiduciaries, so they don't act that way. But those who are legally obliged to be a fiduciary, they can actually be punished if they don't. So,
And I guess someone who has power of attorney has the right to have this person get health care if needed.
that's a separate issue. I'm just talking about what
Oh,
fiduciary means.
Okay.
So healthcare doesn't follow free market principles. If you think about it, when you go to the doctor and they say you have this diagnosis and I can't give you a diagnosis unless I give you tests, you're going to be paying that doctor and paying for that test, that lab test, without knowing what it is you're going to be ultimately paying for, because you don't know what you have. And the doctor can't tell you what's going to happen in order to make a diagnosis or a treatment. And the doctor can't tell you what's going to happen to you. It's not like buying a car. And when you get to an emergency room, being told it's your money or your life, that's coercion. It's not choice. So when you think about how healthcare works, it's not like buying a car. Corporations have a fiduciary duty to investors, not to consumers. They are required to put profits over patients and customers. So free market principles don't actually apply to healthcare or other sorts of public good, because with public good, we call it profiteering when companies raise the price on water in emergency. But raising the price on a drug to what the market will bear is perfectly fine. Actually, it's a good idea, right? And rationing by wealth, when health resources when you find Louis Vuitton and Tiffany in wealthy zip codes, that makes perfect sense. But when health resources are in wealthy zip codes, and they're not in poorer zip codes with poorer, less healthy people of color, we're kind of offended. In New York City, zip codes are a very good proxy for expected life expectancy. And in New York City, based on the wealth of the zip codes, some of which are 10 blocks away from each other, the longevity can be as much as 8 or 10 years. Now, the question is, why in New York City should those zip codes have such different health expectancy? And the issue is the wealth of the residents and how many health providers there are. And you look at New York City with looking at by income level and the redlining from 1930s, and it is remarkably aligned with where the life expectancy is. So good health enhances national security, economic security, democracy, and those two belonged on the earlier slide. Why paragraph 3? This is 2 questions. One is, are current private actors in the health sector failing the public? Is kind of where I would go here. So if you read the news, we've got lots and lots of hospitals closing. 50 in New York State since 2005, and about 6 in New York City since 2018, including, you've probably heard of Beth Israel and Mount Sinai recently. But when you go out and look at the map, all of the orange, these were all the counties in the US. The orange counties have no ICUs, and you notice that New York State has a number of counties without an ICU. And the gray has no hospital at all. New York has 4 counties without a hospital. But look how many counties in the US have no hospital. Many have closed. We've had close to 500 hospitals close in the last 30 years. Obstetric care, another issue. All over the country and in New York State, maternity wards have closed. When you look at a map, the dark blue have no hospitals or birth centers. The pale blue has 1 hospital or a hospital that has a OB/GYN or delivery centers. Look how much of the country you have to drive a long way to get to a place where you can have a relatively safe delivery. It is no wonder that maternal mortality in the US is 3 or 4 times worse than the average of Europe. And Black maternal mortality is double or triple that. We don't take care of pregnant people that we want to keep alive. Okay, privatizing also raises prices. When you've got private equity acquisitions that then monopolize, physician practice costs go up 20%. Let's look at what happens. This is a P&HP slide. So when private equity takes over a hospital, the number of staff goes down, the number of nurses goes down, the number of staff per bed per day goes down, but the profit goes up. And there's many, many charts like this. When you look at hospices and nursing homes, and you look at high and low performing by family assessment, 1/3 of the bad performers are for-profit, whereas only 1/8 of the not-for-profit are bad performers. There was a ProPublica article that was really, really long 2 years ago that talked about the hospice movement and how it has become a complete for-profit hustle with abuse, fraud, overbilling, under and over treatment, and so much patient harm. This is just, it can bring you to tears, this article. So for-profit hospitals have the highest, then there's also the issue of quality. Readmission is a function of quality. when a clinic or a hospital sends you home and you bounce back within 30 days with the same condition or a byproduct, that is considered a quality fail. The red are the for-profit hospitals with readmissions for each of these conditions. Pneumonia, COPD is breathing, joint replacements, heart failure. The orange and green are the nonprofit and public. You see how there is a huge difference with for-profit hospitals. PNHP has done a lot of studies for this. This is Physicians for a National Health Program. Medicare is being privatized. Taxpayers, this is a little 15-page booklet, which is easy to read, and it's listed on the website. We are paying between 100 and 140 billion in excess profits and waste annually just on Medicare Advantage privatization. Overbilling, fraud, all kinds of things. Now, the US often doesn't want to weigh into this because healthcare is so complicated, but they signed on to a letter with 200 allies in June that went to the Federal Trade Commission, the US Department of Justice, Health and Human Services, and in the first page or so, this set of sentences shows up. Private equity and healthcare are incompatible because it results in spiraling prices, diminished access, declining quality, including unnecessary illness, injury, and death. The essence of healthcare is an ethical commitment by autonomous, highly trained professionals to the improvement and well-being of their patients and clients, but it's undermined by private equity's financialization strategies that emphasize maximizing profits above all. And the concluding paragraph, equally strong, markets function best with competition and a free flow of information about prices and quality. The healthcare system functions best when everyone has adequate access to care and decisions are made in the best interest of patients and communities, rather than owners and investors seeking to maximize financial return. The unfettered pursuit of profit is unhealthy for the American economy and for the communities that suffer from it. And then it urges these three government agencies to act. We'll see how that works out. So I would just say, how could we use this? How could we use this? Mainly, we will have to get New York State to agree, and one way to get New York State to adopt this is to get a number of local leagues to adopt it. But there's a lot of legislation, and we're almost out of time, so I want to be under rather than over time. We can deprivatize state-level Medicaid managed long-term care. There's a bill for this. And the Department of Health did an audit. For-profit insurers are charging up to 25% admin plus premium plus profit in order to provide this service, and they're not providing any service. They're just reimbursing healthcare aides for doing this. Connecticut privatized it about 10 years ago and saved billions and billions every year, and is still saving money because rates do not increase as fast when the government is just doing it at cost. So there's lots of things we can do. So one last question. Do we need this position if there are other league positions that already encompass support for it? So I would make 2 points. The new position eliminates inconsistent interpretations around healthcare explicitly as a common good, and the league support for deprivatizing bad actors who harms the public. There's a bunch of inconsistent interpretations around that. So it will be more useful when evaluating legislation because it's support for public control of public goods, whether or not they're owned or managed by private entities. And it gives economic reasons as well as moral imperatives. It makes them explicit for supporting it. So that's it. Thank you. I will hand it over. If there's a couple of questions, I'll take them, but I think mainly we could go to Joe and focus on the position, because healthcare is such a big topic that it will be easy to talk about healthcare rather than this position. Does that make sense?
Yes.
And I will look at the chat.
Terrific. All right. Well, thank you, Judy. And a reminder, please turn off the recording so
Oh,
that
thank you. Perfect. Yes.